our partner, Tony McDowell from Virginia Opioid Abatement Authority, to welcome you all and get this started.
Thanks, Donna. Good morning, everyone. Again, my name is Tony McDowell with the Opioid Abatement Authority, and we are very pleased to serve as a co-sponsor of this event. And I'm going to be brief because we have a lot of content to get through today. But, for many people across Virginia who are struggling with substance use disorder, and particularly with opioid use disorders, one of the first times that they have a chance to sort of acknowledge that they have a problem and connect with people who can provide help is when they get arrested and put in a local jail, and when they go through the correction system. And so maybe there's a way that we can break the cycle of arrest and incarceration and addiction by providing services to people when they're in the incarceration environment. In fact, I think it's a fair statement to say that there's probably no larger single provider of services in Virginia for people with substance use disorders than in our jail and prison system, and that's unfortunate. But we realize that that's a big lift, and there's a lot of effort that needs to go into making this successful. And so the Opioid Abatement Authority is pleased to be a partner with localities, with regional jails, with Department of Corrections, to be able to provide access to resources, and by resources I mean money, to help us implement programs that can save lives and help people that are sick and suffering, while at the same time protecting the safety of our communities. And so this is an important topic for us. I applaud each and every one of you for participating, and I'll be here as an attendee, and then as a presenter on the third day, the final day, to talk about how your organization can use opioid settlement funds to implement or expand programs in the correctional environment. And so with that, I'll conclude my comments. Again, thank you to Donna and to Bay Rivers Telehealth Alliance for putting this together.
Thanks so much, Tony. Welcome to all who are participating today, and my apologies if you had some difficulty getting in on the link. We're still working on including additional people in this webinar. But we're really excited about the folks that we have presenting today. And you should have received in your email, follow-up email from Eventbrite, a detailed copy of our agenda with bios and wonderful pictures of our speakers. And we're just thrilled to have all of our speakers here join us, and all the speakers throughout our three-part series. Today's presenters are really focusing on the why. Why do we need to develop these programs for our correctional institutions? And we're going to start right out with Steve Gordon. Steve is a civil rights enforcement coordinator for the U.S. Attorney's Office, Assistant U.S. Attorney for the Eastern District of Virginia. It's a wonderful presentation with a lot of great content that I've wanted to look at several times. And so Steve, I'll turn the microphone over to you.
Great. Thank you so much. And I really appreciate the invitation to speak here, Donna and Anthony as well. So as Donna mentioned, I'm with the United States Attorney's Office, and we enforce the Americans with Disabilities Act. And the Americans with Disabilities Act has a lot of relevance to this particular issue. So I'm going to walk us through, and let me talk a little, give you an overview of what I'm going to talk about today. First of all, I'm going to give everyone some background on the ADA. Because all entities in state and local criminal justice settings are covered by the Americans with Disabilities Act. And the ADA covers a broad range of disabilities, including addictions and substance use disorder. So another thing I'm going to talk about is the importance of medications for opioid use disorder to treat opioid use disorder. And there are 3 FDA-approved medications for OUD that have been proven to be highly effective, and they save lives. And I'm also going to talk a bit about an alternative that some correctional facilities use, and it's really problematic, and that's supervised withdrawal. Most patients with OUD who undergo supervised withdrawal will start using opioids again and won't continue with recommended care. And I'm going to talk a bit about that as well. I'm going to also talk about the requirement that state and local correctional facilities provide access to all 3 of the FDA approved medications. I'll talk about the importance of designating an ADA coordinator. And this is a legal requirement as well. And then I'm going to talk about potential collaborators. And you're going to hear from some of the potential collaborators through this webinar series as well. But if you're sitting there thinking, oh my gosh, how am I going to implement this in my facility? You're going to get some great information on the nuts and bolts of doing that through the webinar. All right, so let's start off with a very important resource. The Department of Justice has a website called ada.gov. And most of the things that I'm going to talk about today, you will find on ada.gov. It includes the statutory language, the regulations, technical assistance, settlement agreements. By the way, the settlement agreements in the OUD area are very important. They provide a roadmap. And I'm going to talk about one in particular, a settlement agreement reached just at the end of last year with the Allegheny County Jail in Pennsylvania. And it has a roadmap of the types of things that you need to do in order to bring your facility into compliance with the ADA. So there's an old version of ada.gov that you're seeing on this screen. And by the way, when you see the underlying text in a different color, those are hyperlinks. You'll get access to my presentation, and you can just click on those and it'll take you right to the item that is hyperlinked. And the old version of ada.gov, a lot of people who are law-oriented or lawyers really like this page because it's organized a little bit more in a lawyer-friendly way. So the department has 3 technical assistance publications that are really useful and helpful. One is called Commonly Asked Questions About the ADA and Law Enforcement. Another is Examples and Resources to Support Criminal Justice Entities in Compliance with Title II of the ADA. And then the final one is just called Opioid Use Disorder. And that publication explains why the ADA applies to individuals with opioid use disorder and some of the things that you need to do. And this is what that publication looks like. And again, you can see the blue text with the underline. And if you click on that, you'll be able to get right to that technical assistance publication. So what's covered by the ADA? All state and local governmental entities are covered. All right. And it's really important to understand that. And a public entity subject to the ADA is any state or local government entity, any department, agency, special purpose district, or other instrumentality of a state or a local government. Why is that important? We have 22 regional jails here in Virginia, and they are compacts between multiple government entities. Those are all covered by the ADA. All right, so let's talk about the entities that are covered by the ADA. It's regional and local jails, state prisons and correctional facilities. The healthcare providers within a correctional facility are covered by the ADA. Community corrections, including probation, work release, and pretrial services are covered. The courts are covered. And so are state and local social service agencies like the community service boards. And I hope a lot of people know what the community service boards are, but they are the local mental health agencies here in Virginia, and they are covered as well. So Virginia Sheriff's Departments are responsible for operating local and several of the regional jails in Virginia. And Virginia has 123 elected sheriffs and over 9,000 sheriffs and deputies. And Virginia also has 71 jails and 20 local jails and 22 regional jails. And the sheriffs are responsible for running all local jails and several of the regional jails. The local inmate average daily population is more than 28,000. Okay, so very important. It's a large population of people. And the ADA applies to all aspects of corrections: medical and dental care, mental health services, work release. These are all covered. And by the way, so is probation and parole. If a jail, medical or mental health services are provided by a contractor, the entity that operates the jail is legally responsible for the contract's ADA compliance. So if you're thinking to yourself, well, we got a contractor in who does that work, I don't need to worry about this, that's not legally accurate, right? The jail's administration has legal responsibility for what goes on when it comes to the ADA by their contractor. And the Department of Justice has explained in the section by section analysis of the regulations that all government activities of public entities are covered, even if they are carried out by contractors. And the Department of Justice also explained that through its experience in investigations and compliance reviews, the department has noted that public entities contract for a number of services to be run by private or other public entities, for example, medical and mental health services and drug treatment programs, all of which must be operated in accordance with Title II of the ADA. All right, so another thing that's important to note is that if a jail enters into a contractual relationship for correctional, or I'm sorry, if a state or local government enters into a contract for correctional services with another public entity, the original correctional agency is still responsible for ensuring that the other public entity complies with Title II. So if you transfer one of your inmates to another jail and they're not complying with Title II of the ADA, you still have responsibility for that issue. So very important, you can't contract away your ADA obligations. So what are examples of discrimination under the ADA? So failing to afford a qualified individual with a disability an opportunity to participate in a benefit or benefit from the aid, benefit, or services that is equal to that afforded others. This is very important in the OUD area. Jails in Virginia are required to provide medical services. And if you're providing medical services, let's say for diabetes, you also have to provide appropriate medical services for opioid use disorder. Failing to conduct individualized assessments to determine how to ensure equal access. You have a blanket policy in your jail, okay? That can be an ADA problem if you are required to conduct an individualized assessment for that particular inmate. Failing to make reasonable modifications in policies, practices, or procedures, okay? This is an important one. Even if you have a neutral policy, all right, and you don't modify that policy to ensure that people with disabilities are not discriminated against, that can violate the ADA. Using eligibility criteria that screen out or tend to screen out people with disabilities from programs or services. Some places have a policy that if an inmate is taking medications, they can't participate in a work release program. That can violate the ADA as well, okay? So individualized assessments are key because one-size solutions do not fit all. And you can see equality. This is where everyone gets the same thing across the board. And if everyone gets the same size bicycle in the first panel, that is not going to work. Person in a wheelchair is not able to use the regular bicycle. And for two of the people, the bicycle doesn't fit them. Equity is what the ADA seeks to achieve, and the bottom panel shows you what equity looks like. All right, so here's another illustration. In the left panel, you see that there's someone who uses a wheelchair trying to get over a curb, and a gentleman who has a cane, he's blind. And they all get the equal thing, they get the curb, okay, regardless of what's needed or right for them. And in the right panel, you see that there's a curb cut, and you also see the circles by the traffic signal, and everyone gets what they need, understanding the barriers, circumstances, and conditions. That's what the ADA requires. It's equity. Actions required by the ADA are not special privileges, but instead measures that ensure accessibility and equity. The ADA applies to many types of disabilities. I'm going to be talking about one of those disabilities today. But what is the definition of disability? It's very broad. Say physical or mental impairment that substantially limits one or more major life activities. A record of such an impairment or being regarded as having such an impairment. In 2008, Congress amended the ADA because it wasn't happy with how the courts were interpreting the definition of disability. So if you see decisions that predate 2008, know that they have been overruled by Congress if they go to the issue of the definition of disability. So very important to look at ADA Amendment Act cases when it comes to the definition of disability. So physical or mental impairment includes drug addiction and alcoholism, right? That's in the regulations. You can see the site to that. So now let's talk about the ADA and the opioid crisis in particular. So substance use disorder in the United States, okay, over 17% of people aged 12 or older, or almost 49 million people, have substance use disorder. During my presentation, I'm going to be talking about something called the Substance Abuse and Mental Health Services Administration. It is operated by the United States Department of Health and Human Services, and they are the experts in the field. Okay, they put out a lot of good materials. They have some materials that help correctional facilities as well. And I'm going to refer to them as SAMHSA during my presentation, but it's a very important agency to know about. Studies show that approximately 20% of incarcerated individuals in the United States have opioid use disorder. Okay, and it's also important to know that the ADA specifically prohibits discrimination against individuals with disabilities, not just based on invidious affirmative animus, but also based on thoughtlessness, apathy, and stereotypes about people with disabilities. And there's a lot of stereotypes in the area of opioid use disorder, and I'm going to talk about some of those. So it's very important to know, unlike some other discrimination laws, which require you to show affirmative animus, under the ADA, you don't need to show that. Okay, so your apathy, thoughtlessness, lack of knowledge, stereotypes, those are all enough. Okay, so substance use disorder, including OUD, is a chronic disease. Right, one of the stereotypes that Surgeon General Murthy has addressed, right, having substance use disorder or opioid use disorder is not a moral failing. Okay, that's a stereotype. It is not a moral failing. And here's what Surgeon General Murthy had to say about this. For far too long, too many in our country have viewed addiction as a moral failing. This unfortunate stigma has created an added burden of shame that has made many people with substance use disorder less likely to come forward and seek help. It has also made it more challenging to marshal the necessary investments in prevention and treatment. We must help everyone see that addiction is not a character flaw. It is a chronic illness that we must approach with the same skill and compassion with which we approach heart disease, diabetes, and cancer. All right, so it's a very important concept. The stereotype that addiction is a character flaw is just that. It is not a character flaw. It is a chronic illness. All right, now it's really important because in 2021, the last statistics from the CDC show that nearly 107,000 people died of a drug overdose, with 75,000 of those deaths involving an opioid. And the overall rise in overdose deaths is largely attributable to the proliferation in the drug supply of illicit fentanyl, a highly potent synthetic opioid. So let that sink in. Over 100,000 people died in 2021 of drug overdose. It's a major health crisis here in the United States. And you can see from this chart, which charts the overdose deaths in the United States from 2001 into 2021, that the totals have been on an upward trend and have been increasing. Okay, so very important. They've been dramatically increasing in the last 2 decades. And folks in corrections, you can have a real impact on this. So let's talk about substance use disorder here in Virginia. Okay, in 2022, the Virginia Department of Health reported that close to 2,500 people died of drug overdose here in Virginia. 79% of overdose deaths in Virginia involved opioids, fentanyl analogs, or tramadol. So it's very important, okay? Well, it wasn't just deaths. There also were over 22,000 drug overdose emergency department visits among Virginians. Right? These are the stark statistics. This is what we're trying to address. So let's talk about the legal principles. Opioid use disorder is a disability. It substantially limits major life activities such as caring for oneself, learning, concentrating, thinking, and communicating. Opioid use disorder also limits the operation of major bodily functions, such as neurological and brain functions. The determination of whether an impairment substantially limits a major life activity is made without regard to the effect that ameliorating measures can have, including medication. All right, so very important. If someone is taking medications for OUD and they're not actively using illicit opioids, they are still a person with a disability under the ADA. So the FDA has approved 3 medications to treat OUD: methadone, Suboxone, which is the brand name, and now naltrexone. Right? Very important. All 3 must be available under the ADA. Let me repeat that. All 3 must be available pursuant to the ADA. Right? There's broad consensus that medications are necessary to treat OUD. SAMHSA, remember I talked about them a moment ago, the Substance Abuse and Mental Health Services Administration, has comprehensively detailed the broad and well-established consensus in the medical and scientific communities that these medications are necessary for the effective treatment of many individuals with OUD. And SAMHSA has put out what they call a TIP, a Treatment Improvement Protocol, TIP 63. It's a 330-page document that exhaustively goes through the well-established medical and scientific data on this, right? So if you're sitting there thinking, well, I've heard it really doesn't work, this has been scientifically proven. The evidence is there. So how do medications for opioid use disorder work? And for shorthand, I sometimes refer to them as MOUDs. Sometimes they're referred to as medication-assisted treatment, MATs or MATs. So according to SAMHSA, all 3 medications, when appropriately administered to patients for whom they are clinically indicated, can improve patients' health and wellness by doing the following: normalize brain chemistry and body function without the negative and euphoric effects of illicit opioids. Okay, so this is a really important. It's kind of like insulin for diabetes, which also normalizes blood chemistry. All right, so it's a very important aspect of how these medications work. Another one is they blunt or block the euphoric effects of illicit opioids. So literally, they're blocking the euphoric effects. They make them ineffective. They reduce or eliminate cravings to use opioids. All right, again, another important medication effect is reducing and eliminating the cravings. And for methadone and Suboxone, they reduce or eliminate withdrawal symptoms. Also very important. So these medications are safe to use for months, years, or even a lifetime. We're going to talk a little bit about another myth about the medications in a moment. But the medications have been found to be safe months, years, or even a lifetime. So remember I said you got to provide all three. Medications for opioid use disorder are not interchangeable. So while all three OUD medications can be effective for certain individuals with OUD, they are not interchangeable. They have different pharmacological properties that elicit different responses from different patients. And again, I'm going to refer you to the SAMHSA Tip 63. This is the science. A medical provider's decision about which OUD medication is appropriate for a particular patient will depend on an individualized assessment. So remember, and this is out of the tip that I am quoting, but they're saying the same thing that we say under the ADA. You've got to do an individualized assessment of the patient's medical, psychiatric, and substance use histories, their current level of physical dependence on opioids, their prior responses to medication, their occupation, their pregnancy status, and their treatment preferences. You need to have a qualified medical provider conduct the individualized assessment. So if you have a medical provider who says across the board, I don't prescribe medications for opioid use disorder, I just don't believe in it, that's not a qualified medical provider to make these decisions. All right. You've got to have someone who's qualified in medication for OUDs to figure out what OUD is going to be necessary. So maintenance treatments. Some patients are going to need medications for OUD as a maintenance treatment. And how long a patient receives opioid use disorder medication is also tailored to the needs of each patient. And in some cases, the treatment can be indefinite. The best results occur when a patient receives medication for as long as it provides a benefit, approach known as maintenance treatment. Okay. And again, this is from the SAMHSA Tip 63. All right. And it's really important. This is not something you arbitrarily say, okay, we're going to take you off of that now. All right. It has to be done for medical reasons and with medical knowledge. So denial of medications for opioid use disorder causes great harm. The medical and scientific evidence summarized in SAMHSA's Tip 63 makes clear that if a jail categorically denies access to even one of the three FDA-approved opioid use disorder medications without individually assessing the medical needs of those to whom it is denying access, it will prevent many incarcerated people with OUD from accessing the only medication that will effectively treat their disability. All right, really important. Even if you deny one of the medications, it's problematic. If a jail refuses to provide any FDA-approved OUD medications and instead puts all individuals with OUD through medically supervised withdrawal, it inflicts even greater harm. It not only denies those with OUD access to the most effective evidence-based treatments available, it increases the likelihood that they will overdose. So if you think you're helping someone by making them go through medically supervised withdrawal, that is medically wrong. You are not helping them. It increases the likelihood of overdose. Very important, okay? And again, that's a stereotype and a myth that somehow withdrawal is better than taking medications. And that is not what the science and medical evidence show. And that's what we need to follow. And that's a legal requirement to follow. So what are the myths, fears, and stereotypes about medications for opioid use disorder? One is that MOUDs substitute one addiction for another. That's a myth. It is simply wrong. It's like saying that someone with diabetes shouldn't be taking insulin. Someone needs medication, they need medication. It is not simply substituting one drug for another. And I think Dr. Gay is going to talk a bit about that after my presentation as well. So medications for OUDs is inferior to quitting. That is medically and scientifically wrong as well. All right, and the SAMHSA tip goes through that. Medications for opioid use disorder patients sell their drugs. And while there might be occasionally this going on, this is not something that happens all the time. All right, and you're going to hear from Laura Yeager and from others who have run successful medications for opioid use disorder programs in jails and how they have addressed the issue of diversion and how they have successfully addressed that issue. Another myth is that medications for opioid use disorder is dangerous. That's a myth as well. These drugs have been approved by the FDA, and SAMHSA, as I said, has done a comprehensive study. So now let's talk about the realities. So according to SAMHSA, MOUDs have been shown to give people the time and ability to make necessary life changes associated with long-term remission and recovery, minimize cravings and withdrawal symptoms. MOUDs have allowed people to better manage other aspects of their life, such as parenting, attending schools, or working. And they provide a much better chance of patients discontinuing illicit opioid use over the long term. Okay, so these medications work, and this is how they work. And much like insulin for someone with diabetes, it helps a person to manage their life better. All right, more realities from SAMHSA about medication-assisted treatment. It has been shown to improve patient survival, increase retention in treatment programs, decrease illicit opioid use and criminal activity, increase patients' ability to gain and maintain employment, and improve birth outcomes among pregnant people with opioid use disorder. So you can see there's a lot of benefits to opioid use disorder medications. Okay, so very important to look at these benefits. So Dr. VOAA, who is the director of the National Institute on Drug Abuse, which is another federal agency, has really summed it up well. She explained that medications for opioid use disorder are safe and effective. They help sustain recovery and prevent overdose deaths. She also explains that failing to use safe and life-saving medications is devastating for people denied evidence-based care. What's more, it perpetuates opioid use disorder, prolongs the overdose crisis, and exacerbates health disparities in communities across the country. So medications for opioid use disorder are incredibly important, right? And you're going to hear more about the science from Dr. Gay. All right, so post-release opioid-related overdose mortality is the leading cause of death among people released from jails or prison. Right, so listen to that again. When people have opioid use disorder and they're released from jail, the leading cause of mortality is overdose. And a seminal study done in the United States demonstrated that after controlling for demographic factors, individuals released from prison in Washington state had 129 times greater risk of drug overdose in the first 2 weeks post-release relative to general population. And the majority of those overdoses involved opioids. So it's really important, okay, to have an MOUD program. It's also important to connect up people when they leave jail to medications on the outside. And you're going to hear from Dr. Gay and also from Laura Yeager about what they call the warm handoff program to ensure that people are being handed off to the local mental health services. And here in Virginia, the community service boards All 40 of them have medication for opioid use disorder type programs, as do others. Okay, so it's important to ensure that people are getting the treatment in jail and that they have a continuation of care when they leave. So MOUDs can significantly reduce the risk of overdose deaths. A recent study showed that people with OUD were 82% less likely to die of an overdose when they were receiving MOUDs than when they were not. All right. Again, 82% less likely to die. So there's a Rhode Island case study on medications for opioid use disorder. It's a very helpful study. In Rhode Island, it's a little bit different than Virginia. They have a unified prison and jail system. So here in Virginia, we have the Virginia Department of Corrections, and then we have regional and local jails. Rhode Island, it's all unified. They implemented opioid screening and treatment in 2016, and incoming inmates are screened to determine if they have opioid use disorder. And inmates who were taking medication for opioid use disorder upon intake were permitted to continue. Inmates with OUD who were not taking MOUDs upon intake were given access to MOUDs. Okay, so induction, very important. And they were offered all 3 FDA-approved forms of MOUDs. And there were links for individuals to medications for OUD in the community after release. As I mentioned, it's also called a warm handoff. So all of these things were present in the case study that was done in Rhode Island. And what did they find? They assessed post-release mortality, and there was a 61% reduction in post-release deaths. 61% reduction, very significant. And overall, in Rhode Island, there was a statewide reduction in opioid overdose deaths of 12%. They moved the needle on this issue in Rhode Island. And you too can help to move the needle on this issue here in Virginia. So Title II of the ADA prohibits public entities, including regional and local jails in Virginia, from discriminating based on disability in the provision of their services, programs, or activities. And regional and local jails in Virginia provide health services to incarcerated individuals. And that's done under Virginia law. You're all required to provide health services. And the ADA requires that people with OUD be given an equal opportunity to benefit from healthcare services. These are ADA requirements. When a jail categorically limits access to medications used to treat OUD, without individually assessing whether they may be medically necessary to treat specific individuals with OUD, the jail denies those individuals an equal opportunity to benefit from its healthcare services and violates the ADA. Denial of medications for OUD violates the ADA. Decisions about access to medical treatment that rests on stereotypes about individuals with disabilities rather than an individualized inquiry into the patient's condition will likely be considered discriminatory. Withholding a medication used to treat addiction without an individualized inquiry into a patient's condition will likely be considered discriminatory. The ADA covers maintenance treatment that has already begun prior to intake at a detention facility. In correction facilities, not medically assessing intakes to be induced into MOUDs is a matter of policy, even though other medical conditions such as hypertension are evaluated. Okay, so the ADA covers that too, and that's problematic. Discontinuing people on treatment because they are illegally using other drugs. The ADA also covers that, and that can be problematic too. Mandating people onto specific forms of medication as a matter of policy rather than as a matter of individualized assessment can be problematic. Mandating people off of specific forms of medication in drug court, okay, that can be a problem unless there's medical backing for it, okay, and that means a qualified practitioner. Mandating people onto a specific form of medication as a condition of parole. That could be a problem under the ADA as well. Again, unless there is a medical opinion for that. All right, so there's been a lot of ADA, opioid use disorder enforcement activities. Private lawsuits have become very frequent, and the courts have been unanimous upholding access to medications. And I'm going to talk about one of those decisions. The Department of Justice, along with the U.S. Attorney's offices, and we're part of the Department of Justice, has initiated compliance reviews and investigations of correctional facilities. And the Office of Justice Programs, which provides federal grants to entities in criminal justice settings, has also initiated compliance reviews on grant recipients, as compliance is often a condition of funding. Okay, so very important. There's a lot of different ways that you can get yourself into legal trouble if you're not offering medications for opioid use disorder. Private lawsuits, the Department of Justice, Office of Justice Programs. We can all come in and take a look at what you're doing. So one of the leading cases in this area is a case called Smith versus Aroostook County. And this is a decision of the United States Court of Appeals for the First Circuit. And it upheld a district court decision granting a preliminary injunction under the ADA when a county jail had a blanket policy of prohibiting inmates from taking medication-assisted treatments during incarceration. All right, so very important. Okay, this is a very important case. So you can see that there's a second case involving a Massachusetts jail that has the same holding as this First Circuit case from Maine. So medically supervised withdrawal likely violates the ADA. And the court in Aroostook County case held that the jail's general policy of putting individuals through medically supervised withdrawal rather than providing them with OUD medication likely violated the ADA. Okay, so very important. That's what they say, what the courts have been saying about supervised withdrawal. So an example of a DOJ enforcement action comes out of Allegheny County Jail in Pennsylvania. And this settlement agreement was entered into in December. And in that case, Allegheny County Jail refused to provide an inmate with methadone, which I said is an FDA-approved medication for OUD, even though he was receiving it from a licensed provider prior to his incarceration. Okay, so that's what they were doing. And we entered into a settlement agreement, the Department of Justice, and you can see the settlement agreement is in red and it's underlined and highlighted. If you click on it, you can go and take a look at the settlement agreement. And paragraph 13 provides a roadmap for what jails need to do in this space. And I paraphrase it on these slides. I do recommend taking a look at it. And it requires jails, in this particular case, the Allegheny County Jail, to evaluate inmates for OUD at the outset of their incarceration to determine if medications for OUD would be appropriate, including those who were not previously receiving medications for opioid use disorder, right? So it's not limited to those who are receiving it. And that's very important, okay? Because that's the whole induction concept. It also requires that they provide inmates with access to FDA-approved medications, all three of them, to treat OUD, including both individuals who are taking MOUDs when incarcerated and those who are not taking MOUDs but would benefit from them. The settlement also requires the jail to maintain an individual taking a particular medication to treat OUD unless a qualified medical provider concludes that the medication is no longer medically appropriate. It also has a requirement that the jail not use incentives, rewards, or punishments to encourage or discourage individuals from receiving any particular medication to treat opioid use disorder while they were in the Allegheny County Jail's custody and control. Right? Again, this is a roadmap. You want to figure out, what do you need to do to bring yourself into compliance with the ADA? Take a look at the Allegheny County Jail settlement agreement and it'll provide you with a good start, okay, a good beginning. All right. The department has also looked at what state courts are doing. And there is a case involving a court, or courts actually, more than one court in Pennsylvania, where judges were ordering individuals to stop taking prescribed medications for OUD, okay, without any medical backing. They just had across the board, we're going to stop you from doing this. If you take a look at the settlement agreement, it requires the court system to adopt an ADA compliant OUD policy and train all the judges about medications for opioid use disorder and disability discrimination. Right? So really important. The courts can't violate the ADA either. All right. And the Department of Justice has a settlement agreement with a Virginia court outside of the OUD area, but an ADA case. So know that that's important, and you can't hide behind what the court does either in the jail. So you want to learn more about the Department of Justice's position on the ADA and medications for opioid use disorder. The department filed a statement of interest again in December in a case called Strickland versus Delaware County. And you click on it and take a look at it, and you can see what the department is saying in court about this issue. The department also issued a letter of finding in the Pennsylvania court case that I mentioned. It also has a good discussion of the department's views of what the law requires. All right, now I'm going to shift gears a little bit and talk about Americans with Disabilities Act coordinators. The ADA regulations require a public entity that has 50 or more employees to designate at least one employee to coordinate its efforts to comply and carry out its responsibilities under the ADA. Okay, very important for jails to have an ADA coordinator, right? It's a specialized area. In addition to having the ADA coordinator, public entities like jails need to make available information, contact information, for who has been designated as the ADA coordinator. All right, and best place to put that is up on your website. And it's really important to have ADA coordinators. It's legally required. And the section-by-section analysis of the ADA regulations explain the rationale for designating an ADA coordinator and the requirements for the designation of a particular employee and dissemination of information about how to locate that employee helps to ensure that individuals dealing with large agencies are able to easily find a responsible person who is familiar with the requirements of the ADA and its implementing regulations, and can communicate those requirements to other individuals in the agency who may be unaware of their responsibilities. Right? I have found when I look for ADA coordinators in a variety of jails, many of them do not have them, and they don't have them up on their website. So check your websites. If you don't have one, get one. And there are lots of supports for ADA coordinators to learn how to do their job. The National ADA Symposium is coming up, and they have an online version in May and another one in person in Minneapolis in June. So it's very important. There's also a group of ADA coordinators for corrections that is formed, that the ADA coordinator for the Pennsylvania Department of Corrections has started. And Barry Morano, who is the ADA coordinator for the Virginia Department of Corrections, can also assist folks. So it's really important. Fairfax County has an ADA coordinator for its sheriff's department as well. And I know that he can assist folks also. All right, you want to read more about ADA coordinators? My office issued a Dear Colleague letter back in 2022 reminding state and local government agencies to designate an ADA coordinator. And you can learn more about this. Why is it so important? Well, to understand things like the requirement to provide medication for opioid use disorder, to understand what you're supposed to do with other types of disabilities that may be confusing for people. Like if you have an inmate who's deaf, or you have an inmate who has diabetes or epilepsy, you need to understand what you're supposed to do. having or an inmate who uses a wheelchair. Okay, really important. And you can click on the link here and get right to the letter. All right, potential collaborators. You're all probably thinking, well, how am I supposed to do this? This is kind of complicated. So first of all, obviously the Virginia Opioid Abatement Administration is a wonderful collaborator. They have co-sponsored this event. You're going to hear from them about funding opportunities. In short, they have received funds from the multi-state settlement agreement with the opioid manufacturers and distributors. They were set up by the state legislature to assist with the abatement of the opioid crisis. Fairfax County Sheriff's Department, they are trailblazers on the use of medications for opioid use disorder. And you're going to hear from Sheriff Kincaid and also from Laura Yeager about the nuts and bolts of the program that they have established. They even have a website about their program. Laura Yeager can tell you all the things that she has learned being a trailblazer in this area. And she's going to be doing a presentation as well. Another trailblazer is the Chesterfield Sheriff's Department, and Dr. Gay is going to be speaking after me. And they too have a trailblazing opioid use disorder treatment program that uses medications, right? So you have allies and champions in your community that can assist you in Chesterfield and Fairfax. Okay, very important. All right, another group, Mike Fatula at the Virginia Department of Corrections. And I think Mike is on the call here today. And he and others are hosting a group called Recovery Behind the Walls. And they host the correctional facilities that offer medications for opioid use disorder and those that are interested in learning more about it. The group started in May of 2022 with very few jails involved. And I've heard that as of February of 2024, that 40 jails in Virginia participate, right? And know that that's not all the jails, right? Because there are 71 local and 22 regional jails. But I know there's a lot of practical experience that you can learn, again, from your colleagues who have been working in this space. So it's really important to recognize that you can get help in figuring this out. The Virginia Community Service Boards, I'm hoping that most of the jails have worked with your community service board, but if you haven't, the community service boards function as the single point of entry into publicly funded mental health, developmental, and substance use disorder services. And the CSBs are service providers directly and through contracts with other providers. Some of them provide services in jail through a contract with the jail. And the CSBs serve as advocates for individuals who are receiving or in need of services, and the CSBs act as community educators, organizers, and planners. And all 40 CSBs offer medication for opioid use disorder services. Right? So really important, they're another collaborator who can assist you in your community. And the 40 CSBs cover every single county, city, town, and jurisdiction in Virginia. Okay, so this is the coverage map, and there's no place in Virginia that doesn't have a community service board. Here's my contact information, and I welcome questions as well. But I want to leave that up because you're welcome to call me, send me an email, and I'm happy to chat with you. I, in addition to doing enforcement actions, also help provide technical assistance. And many of the jails here in Virginia and also the Virginia Department of Corrections reach out to me with questions about the ADA. And again, I welcome questions. I don't know if there's some already up in the question and answer spot or in the chat.
Thanks so much, Steve. What a wonderful presentation. And yes, please put your questions in the Q&A Or if you have questions, you can also raise your hand and I will unmute you.
I see a hand went up. It's a couple hands have gone up.
Okay, thank you. Find him. Go ahead, ask your question. Should be able to have unmuted, so you should be able to ask your question.
And it's the person FOWLKESNR. So you've been unmuted. You want to go to maybe the next person?
Hey.
Hello.
Hey.
Yes.
Hi, go ahead.
Okay. My name is Coco. I am the Director of Nursing at Manassas Jail. And thank you very much for this information. And I know that we have started on this program probably 4 or 5 years now. And the biggest issue that I have is I know Mr. Gordon have touched a little bit about it. It's diversion. So I just want to know, what is the responsibility of inmates who are this program? What are their responsibilities?
I'm not quite sure what in what respect you're talking about.
In response to diversion.
Oh, in response to diversion. Okay, and what jail are you with? I didn't quite understand what
Manassas
you're
Jail.
saying.
Manassas Jail.
Manassas. Okay, so Prince William Manassas Jail. Yes, I will say, I think that talking to Laura Yeager about diversion is a great place to go. She's at the Fairfax jail and runs the program, and I know she has done a lot of thinking about how to address that issue. And I don't know, Dr. Gay may have done some thinking in Chesterfield as well. But Laura gave me, and I didn't mention this before, she gave me a 4-hour tour of the Fairfax County Sheriff's Department Medication for Opioid Use Disorder Treatment Program. And I highly recommend folks, and sorry, Laura, if you're going to get a lot of calls about this, but I highly recommend that tour. And she talked about the things that they did to address diversion and the practical steps. And she actually showed us medication administration and the sorts of practical steps that they took. So I think the best thing to do is talk to someone either at Fairfax or Chesterfield Jail about what they've done to specifically address that issue.
Thanks, Steve. Yes, there's a comment in the chat from Laura saying that Dr. Kay will also probably cover this, as will our Laura and Sahana and folks from Fairfax County next month as well. And we have a question in the chat, Steve. Is there a point during the intake process that an inmate can be denied MAT if the individual comes in where they have been charged with a drug charge or is testing positive for drugs?
So the answer is that you cannot deny people MAT just because they're there on drug charges, or even if they've been using, because it's a treatment for that exact thing. So the answer to the question is you can't deny it simply because a person is there on, and in fact, a lot of the people are probably many of them are going to be there on drug-related charges, because that's the nature of this disease, is that people don't think about the consequences because it's such a powerful addiction.
And just checking with the participant with FOWL are you able to share now or ask your question? Looks like you have been unmuted.
And you could also type it in the chat or in the Q&A if you're having trouble with your microphone.
And no, we are not able to hear. I'm sorry. If you could type your question in the Q&A, that'd be great. Give them 1 second. They're typing.
Okay.
Any other questions coming up? Oh, here's one. What the DEA might see as diversion control, the ADA might see as discrimination. Does a regulatory conflict exist between the DEA and the ADA?
I don't think that the DEA says you can deny medications to people who have opioid use disorder. I don't work for the DEA. What I do is enforce the ADA. So the important thing here is to provide these medications, and you have peers like Lori Yeager and Dr. Gay that can tell you how they've addressed the issue of diversion.
Thanks, Steve. Another question. So medical supervised detox is not appropriate anymore?
As I explained, SAMHSA and others and the courts have explained that medically supervised withdrawal is not the way to go. It is not an appropriate treatment. What is appropriate is providing the medications that treat people for opioid use disorder. And it's a myth. Again, it's a myth. And it's a myth that someone born out of the idea that it's a moral failing to have an addiction.
Thank you. Mr. Gordon stated that the jail needs to provide access to all 3 medication types. What is the vendor they are using that only offers 2 of the, what if the vendor they are using only offers 2 of the 3 as they are not licensed to give methadone?
So then the answer to that is they got to find additional vendors, all right? And methadone is becoming more available here in Virginia. I understand, I've talked to some of the CSBs, that there's more and more methadone providers that are out there. So it means you got to supplement your vendor. And when people come to me and say, well, our vendor just doesn't do that in an ADA space. Oh, our vendor provides interpreters, but not sign language interpreters. My response is get another vendor who does provide it.
Okay, we're going to try our friend with the hand raised to see if he can share. Sorry, we're not able to hear you. We do have some other questions in the Q&A.
Okay, and I see a couple more hand raised as well. Nicole and Tupper LR. I don't know if you
We
see
may not get to all our questions, but we're going to try. We've got a few more minutes with questions and answers. Is there a link to regulation policy states that offenders cannot be denied medication for OUD if they were receiving it in the community and the facility tapers due to offender reporting substance use at the time of incarceration?
So you want to take a look at the department's settlement agreement with Allegheny County, Pennsylvania. Paragraph 13 is the roadmap. You also want to take a look at our brief that I mentioned, because that's the statement of the department's position. And, you know, I'm going to go back and provide those again so you can see them. So the statement of interest in Strickland is one of them. So when you get the presentation, take a look at that particular brief, and then take a look at the settlement agreement with Allegheny County. And those represent the department's position on these issues.
Thank you, Steve. There are a couple of questions about how the facilities are housing their inmates, and some medical questions about withdrawn. And I think that would be good to ask our partners from the Chesterfield County, Dr. Gay and Carrie Hauser, who will be on shortly, so that we can really maximize our time here with Steve. I have asked TOPELR to unmute to ask their question.
Yeah, thanks. Ryan Topol, based out of Charlottesville Regional Jail. I just wanted to follow up on ada.gov. I was just checking, I put this in the Q&A, that there's a quote that in the beginning, the ADA protects people in recovery from opioid use disorder who are not engaging in illegal drug use. Which, I just want to clarify. Certainly, I believe that people should continue treatment, but this seems like a caveat that a lot of our inmates are coming in using other substances. But we're talking about how that might not be a qualifier for impeding their ongoing treatment. But it seems like they might lose their disability status as well. So just curious about your perspective.
There's a carve out to that. So if it's treatment for substance use disorder, that is a carve out to what you just read. So people who getting treatment, even for someone who's taking, is something that is covered by the ADA. So continuing to receive treatment or initiating treatment, that is covered.
That part's covered. Yeah, okay, that's fair.
So you can't deny treatment to someone because they're, they've been taking that. That's also a circular problem. And that's
it's just, yeah, it's interesting that they note who are not engaging in illegal drug use. It just seems like it's part of that statement that I just wanted to clarify. It just,
sure,
it seems sticky.
No, I hope I clarified it for you, to explain that getting treatment for drug use is a carve out to what you just read.
Yeah, sure.
Thank you. And Tom Cleary, we have time for one more question. We're going to ask it to be yours. And if you want to put your questions in the Q&A, we'll transcribe those to be able to forward them to Steve.
I just placed one. Can you hear me?
Yes. Go ahead. So
one of our big issues is, besides treatment, is the diversion that we already spoke about. It's amazing what some of these folks can do with oral Suboxone and how it can get moved around. We recently had a patient that brought in 50 Suboxone slips in his anal area and was using them and selling them. My question is that Suboxone injection often avoids a lot of these processes, however, it's expensive. So how can we control the cost difference?
Yeah, and I'm going to refer you over to Dr. Gay or to Laura Yeager. The other thing I'm going to say, Tom, is that I know that the Virginia Opioid Abatement Administration is going to be providing funding. And I understand that the injection is more expensive. But I think that there are ways to address diversion that Laura and also Dr. Gay can talk about. And then there's ways to address the cost issues, which will be addressed in one of the later parts of the webinar series.
Thanks, Steve. And yes, in part 3 of our webinar series, we'll be focusing on funding and different resources. So hope you'll join us, register for that session and join us as well. Thank you so much, Steve. This has been a wonderful presentation. We feel like we could have heard from you for the whole entire morning. And so we will be sure to take some notes and send you additional questions. If you'd like your questions answered via email, we do have your email through the registration, except for the anonymous attendee who asked. So we're going to take a 10-minute break, and we'll be back here at 10:20 to hear from Dr. Gay and Carrie Hauser. And once again, thanks so much, Steve. What a wonderful presentation. Very full of very helpful information.
Thank you. And I left my contact information up if people want to reach out to me. I welcome hearing from folks.
Thanks. To introduce you to Dr. George Montavani Gay, who's the medical director of the Chesterfield County Jail. And you also have his bio, and I'm going to turn the program over to him. But before I do, I just want to apologize to Carrie Rhodes for calling her Carrie Hauser. She's also going to be speaking to us after Dr. Gay. She is the Director of Behavioral and Mental Health Division at the Chesterfield County Sheriff's Office, and we're very excited to have you both here to tell about your amazing program, and I think y'all will have some answers to some of your questions, and as well as even more questions before the morning is out. So, Dr. Gay?
All right. Well, good morning, everybody. Glad everybody's here. And if you can start my slides, that'd be great. Okay. So I'm Dr. Gay. I'm the medical director for the Chesterfield County Sheriff's Office, and I've been the medical director for the past 20 years. So I've seen us go from not having an opioid problem to having an opioid problem to treating all those individuals that have an opiate use disorder and substance use and other substances. Next. So there you see me. I have no disclosures. Next. So some of the things we're going to talk about that you'll get out of this is we're going to review the evidence-based recommendations for treatment of opiate use disorder, understand the morbidity and mortality risks associated with the lack of treatment of people within the criminal justice system. Discuss the barriers to implementation of evidence-based treatment in jails and prisons. Next. So our journey begins. So Chesterfield County, we are a rather large county. We have a population of over 387,000 and a large square miles, 437. And we're one of the oldest sheriff's offices that was established here in the United States, established in 1749. We have over 300 sheriff's office employees and hold currently around 360 inmates in our jail. Next. So as you can see here, this is a graph of the from the Virginia Health Department, and it shows the all opioids fatalities for all opioid overdoses here in the Commonwealth in 2023. And as you can see, for total fatalities, just in the first 3 quarters, we've already surpassed fatal deaths of all of last year, of 2022. So this is data from 2023. So that's a problem. Next. You can see in the year 2020, there were 93,000 deaths from overdose in the United States, and that's enough to fill FBN Stadium in South Africa, I should say, that had a capacity of 94,000 people. So see, all those people died in 1 year. Next. In 2022, 107,000 people died from fatal overdose. And you can see from Penn State Stadium, that holds about 107,000 people. That's a lot of people to die in 1 year from overdoses. Next. And then in 2023, we even had more. We had 112,000 drug overdose deaths in the United States. Now, I couldn't find a stadium that held 112,000 people, so I used AI and made my own stadium. So there's GMG Stadium, which I made with AI. Next. All right, why are we going over this? Why are we talking about this right now? Next. Well, SAMHSA, it is estimated that 63% of people in jail and 58% of people in prison have a substance use disorder. And individuals with this disorder, they have challenges in getting appropriate treatment And often the incarceration exacerbates their symptoms, because if they're not getting treated, they're having cravings, they're having withdrawal. It becomes a real problem for them while they're incarcerated. Next. So as you can see, the number of individuals, let's see, incarcerated for drug offenses between 1980 and 2019. You can see the huge number of the huge increase in individuals incarcerated. So in state prisons, from 19,000 to 176,000, that's a 800% increase. In federal prisons, it was a 1,400% increase, and in jails, a almost 1,000% increase. So there are more and more people coming into jails and prisons that have a substance use disorder. Next. So as the illustrious Steve Gordon just talked about, the ADA, the Department of Justice had a guidance that was issued on April 5th, 2022. And let's go to the next slide. And in that guidance, they talked about, they had several examples, and they were sure to note that one of the examples was a jail. If a jail does not allow incoming inmates to continue taking MOUD prescribed before their detention, the jail's blanket policy prohibiting the use of MOUD would violate the ADA. And with the ADA violations, if you are found, when you get sued, there's a cost to that, not just a private cost, but the cost to the government. Each violation, the first one has a certain amount, and every subsequent violation after that has a higher amount. So it could be very, very costly to get into this problem. Next. This is a document from the Legal Action Center. It's dated June 6th of 2022. There may be an updated one, but this is a multi-page document that has that details a lot of the lawsuits in the criminal justice system. So it's probably about 15 pages long. It's probably a lot longer now. In 2022, the AMA, the American Medical Association, put out their report on the overdose epidemic, and they found that for substance use disorder, almost 93% of individuals that have it are not treated. It's over 40 million people. And any mental illness, 53%, almost 54% are not treated. So that's a big problem, because a lot of those individuals are also in correctional facilities, and also, they have substance use disorder, but they also have mental illness. The little graph on the right on the screen there shows that the number of buprenorphine prescriptions dispensed by retail pharmacy. I only have data up until 2021, but you can see that with the percentages on the side there, there's been a decreasing velocity of buprenorphine prescriptions being filled at pharmacies, and that's a problem. That the velocity should be going up, not going down. Next. Here is the same data for Virginia, and so we were following the same kind of decreasing percentage or acceleration, but toward 2020, we're starting to go up and have more and more prescriptions being filled for buprenorphine. Next. Now, this has been a problem for a very, very long time. Here's a quote from August Vollmer, who was the chief of police in California. And his quote in 1936 says, "Drug addiction, like prostitution and like liquor, is not a police problem. It never has been and never can be solved by policemen. It is first and last a medical problem, and if there is a solution, it will be discovered not by policemen, but by scientific and competently trained medical experts whose sole objective will be the reduction and possible eradication of this devastating appetite." As you can see, this has been a problem for a long time, over 100 years. Next. As you know, it takes as little as 3 to 7 days to lose your tolerance to opioids. Why is that a problem? Well, with recently released inmates with OUD, they are at a significant risk of opioid overdose death. Next. I know Mr. Gordon had mentioned this study before from Washington State. As you can see, here's some of the details. Within the first 2 weeks in their study period, there were 38 deaths that occurred within the first 2 weeks. And of that, there was 27 individuals, which is about 72%, that died. It was attributed to opiates. Next. Also in North Carolina, recently incarcerated individuals are more likely to die from opioid overdose than the general public. You can see on the graph that the 2-week post-release period is a huge high number of individuals that were likely to die from an opioid overdose. But also, this also translates to a year later, where opioid overdoses for people incarcerated outshine those in the general population. So the first 2 weeks after release is individuals are 40 times more likely to die from an opioid overdose. So yes, it is really essential that we treat individuals in the correctional facilities. Next. Part of the treatment is, if you're looking at it holistically, there's medication and there's also programming. And so with the programming aspect, you think of the pair of ACEs. You have adverse childhood experiences and adverse community environments. And so creating your programs to help with thinking, addictive thinking, and how to change your thinking to change your behavior. You also have things to do to help with poverty, mental illness, homelessness. And so here at Chesterfield, we have a reentry program that my colleague will talk about shortly, where we try to help all these adverse experiences to help them overcome that, so that besides the medication, we can help them on when they get back out back in society. Next. So why implement medication for opiate use disorder in jails and prisons? Well, there's a need. The individuals who are incarcerated are at very high risk of opioid overdose upon release. Individuals with OUD have higher risk of being involved in the criminal legal system. There's a bunch of benefits that Mr. Gordon also had mentioned. Reduces return to use of illicit opioids. It reduces risk of opioid overdose deaths. It increases retention in treatment. It reduces recidivism and reduces risk of suicide during incarceration. And so all of those are evidence-based benefits. And also the legal imperative that there's an increase in judicial recognition that MOUD should be standard of care in jails, and failing to provide MOUD violates individuals' rights. Next. So our Sheriff Carl Leonard has a saying: the definition of insanity is doing the same thing over and over again and expecting different results. So with the start of our HARP program and our MAT program, it goes against the grain of what we used to do prior to that. So we can't keep doing the same thing over and over again. Next. So with our HARP, which is helping addicts recover progressively, we did have a name change from in there early on when we were Heroin Addiction Recovery Program, but we've increased the number of people we treat to not just focus on heroin, but on alcohol, sex addiction, gambling, things like that. So it's just helping addicts recover progressively. And as you can see, it was a long process. Started out in 2016 with the males when we started the HARP program. Then we started a female program in September of that same year, 2016. And that was unique because at the time we didn't house females in our jail. So we created a pod, and now we are able to treat everybody. We started our MAT with Vivitrol in 2018. I did get a waiver, a DEA waiver, to prescribe buprenorphine in February of 2020, and right before COVID. So that was interesting. We started buprenorphine treatment in 2021. We also initially started a smart pod where we housed all of our individuals who were on MAT, but we didn't. That didn't last too long because we felt that we could integrate them into HARP, because our HARP individuals that are looking to do abstinence, because we do both. We do medication assisted treatment, and we also have abstinence program. And just with the learning of what both can do, they were merged together and have been doing well ever since. Next. So, our HARP program was started so that we can end the cycle by ending the addiction. As you know, you have drug abuse and crime, you get arrested, you go to jail, you get released, you come back, you do crime, you have drug abuse some more and more crime, you keep coming in with that circle. And so what HARP did, we try to get in between during the time that you're in jail, so that when you are released, our goal is that you don't come back into this vicious cycle. Next. So, medications for opiate use disorder. Next. So, the biggest myth is that MAT is just replacing one drug with another. That is completely false. Next. With successful MAT MOUD treatment, the compulsive behavior, the loss of control of drug use, and the constant cravings and all other hallmarks of addiction vanish. When all signs and symptoms of the disease of addiction vanish, we call that remission, not switching addictions. So you can compare this to somebody who has diabetes or who has hypertension. You treat them, the disorder, you can control it, but it may not go away, but you have to maintain that treatment with the medication. And that's the same way with substance use disorder. It is a chronic disease, not a moral failing. Next. So what's the difference between MAT versus illicit drugs? Well, MAT is prescribed and monitored by a medical provider. All the medications that are used are FDA approved. The medications have regulated potency, and MAT curbs cravings and withdrawal symptoms. Now, with illicit drugs, they're obtained by illegal means. They're not legally permitted in this country. The potency varies. I don't see cartels having really specific guidelines on how to make their drugs. And using those drugs illicitly results in euphoria or a high. Next. Is a graph that I like to illustrate that somebody who starts using acute use of drugs, they may be normal, then they get a euphoria. And as they keep using, their euphoria starts to wane. And then they start to build a tolerance and a physical dependence. And now when they're in withdrawal stage, they're using just to try to get back to normal. They're not even trying to get back to euphoria. They're trying not to be sick. And so trying to break that cycle, that's where medication assisted treatment or MOUD comes in. And that helps quiet the brain, helps quiet all the cravings and the withdrawal symptoms, so somebody can lead a normal life and start to think and be able to do their programming and get all the things that need to get done in a timely fashion, and not have to go out and try to score drugs and lose their job, lose their families, things like that. Next. So what we do at the jail, you're looking from transition from community to jail, you have to do screening and assessments. And then during incarceration, you're doing medication administration and programming. And then the biggest is transitioning from jail to community, where you do where you have a reentry coordination. And so reentry coordination, I believe Carrie will talk a little bit about that when she comes up. But we have a very robust reentry program where we do warm handoffs for individuals. Those individuals that are on medication assisted treatment, we send them back. If they came in on the medication, they are sent back to their respective treatment center. And if there's an induction that we've done, we make sure that we can find somebody that they can go to that's near them, so that they can continue their treatment. Next. So that starts at the jail intake screening. We have our deputies doing basic screening questions, and then we have our nursing assessment, where they perform detailed assessments and determine the next steps of where patient needs to go. And then they can see the provider and assesses for opioid use disorder, for a diagnosis, and appropriateness of medication. Next. Here is a protocol that I wrote for our MAT, and as you can see by the outline, it covers guiding principles, screening, treatment, safety, linkages to care. And so this is something that if a facility doesn't have this is probably one of the first things you should do, is to create a protocol for your program. Next. I have other forms that help us in tracking individuals that come in on medications for opioid use disorder, and which gives us court dates, release date, what medicines they're on, verification information, because everything needs to be verified, urine drug screening of everybody that comes in. So this is very helpful, and that will be helpful to keep you organized. We use the clinical opioid withdrawal score, a COWS score for opiates, and that helps us determine the severity of somebody going through withdrawal. We also use the CEWA, which is for alcohol. Next. So there are 3 FDA approved drugs. First one is methadone, which is a full agonist, and that's available in the pill, liquid, and wafer forms. It's a daily treatment, and you have to be in an opioid treatment program in order to be able to prescribe the methadone. And so that's a big problem for correctional facilities. And so the way we do it is that we contact individuals in the individual's treatment centers and get verification, and then also get exceptions to get take-home doses. And I say take-home in air quotes. And so that we do have somebody that goes out to the different treatment centers and picks up the methadone doses and brings it back to the jail. And we typically get 7 days at a time. So that's the way we're doing it. But we're also looking toward having one facility, one treatment center to guest dose everybody that comes in. That's a way to do that. And so that way you don't have to go to several. At the moment, we go between four and 6 treatment centers. So yeah, it can put some pressure on our transportation and on our staff that go out. But we're also working on trying to get just one place, so only one facility that will help us out. We're also looking at, I know with the state, possibly having a mobile van that will visit the different correctional facilities to bring the methadone to the facility. So that's something else that could be looked at. And the third way is to become an OTP, opioid treatment program at your facility. Now that's a huge barrier because a lot of our places have already been built, and they may have been built 20, 30 years ago. And you may not have the physical plant to have a pharmacy and a locked place where you can have the methadone in order for dispensing. And so any newer facilities that are being built, you might be able to build that in. But at the moment, that could be a problem. The other medication is buprenorphine, which is a partial agonist. And so that is in pill or film form. There's also an implant, but there's also a injectable form. And then the third is naltrexone, which is an antagonist. And as an antagonist, it fully blocks the opioid receptors. So that's also injectable. It's a monthly injection, and that is also something else that can help and helps with cravings. Next. So here are the long-acting injectable buprenorphine products. There's a Sublocade, which is made by Indivior, and then there's a Brixadi, which is made by Braeburn, and these are very, very helpful because I know there was a question about diversion. This may help with diversion because now you don't have, now somebody's not won't be able to cheek the medication. You give it to them once a month in their abdomen. For Sublocade, for Brixadi, you can do it in the abdomen or in the thigh or in the arm, but that helps with diversion, and it also helps your staff that you don't have to do all the things you need to do in order to do daily directly observed therapy with Suboxone or buprenorphine pills or strips. Next. And so here's just a picture of our medication room. We have a little box. We have a little safe there that has a double lock where we keep some of our buprenorphine. But that was early on. And if you look on the picture on the right, you can see up in the top corner above the door, there is a camera. And so when nurses are counting, they're always being observed. Next. So now we have here's a medication safe that we have purchased that has a digital code. So all the nurses will have a unique code to get in. It can track, and we can tell who goes into the safe. Next. And there is a picture of where the safe is. Next. And here's a picture of a bird's eye view of the nurses counting. Period. Next. So part of what we do is when individuals come into the unit, they have to sit with their hands under their thighs. No long sleeve shirts. There's no talking. And then prior to getting them the medication, the nurses look and the deputies look. They also get they have to drink some water to wet up their mouth a little bit. They get the strip. We use strips here, and the film take about 10 minutes to dissolve, and so they'll sit there and we'll watch them. They can't put like I said, they can't talk. They can't put their hands toward their mouth or anything like that to help decrease diversion. And then afterwards, the nurse looks, and then the deputy looks, and we also use a cotton swab to swab the mouth in between the teeth, in between the gums, underneath the tongue, to make sure there isn't any residue. And they also get some water to swish and swallow. Next. So dealing with diversion. I know somebody had a question about that. Patients are dosed in the medical unit under the camera. Like I said, they're watched by the nurse and the deputy. They have to take out the dentures. They have to have short sleeves. They have to sit on their hands. They swish and swallow. We do mouth checks. And we also do periodic spontaneous urine drug screening to make sure that the buprenorphine is in their system. The provider orders the medication electronically. And so when the medication arrives from the pharmacy, we have two nurses that unpack, count, and sign the delivery sheet. Medication is stored in double locked cabinets and separate from other controlled substances. We have a medication logbook to keep it's kept by the safe. Access to the medication is limited only to the desk nurse. So the desk nurse is the only one that has the key to the medications. All medications must be accounted for if wasted or dropped, and everything, all the accounts have to have a cosigner. Discrepancies are immediately reported to the nursing supervisor and our investigation unit, and investigation starts. And all the controlled substance inventory sheets are kept on site for 5 years. Next. So we have we have a patient database that we keep to see what facility they're at, what medication they're on, where their release dates are, and any case notes. Next. We also keep a provider database so that we have knowledge of where all the facilities are so that we can make our warm handoffs. Next. We also do teaching, overdose, and Narcan distribution, and so all of our participants, they get trained, and we put Narcan in their property, along with other things for harm reduction purposes. We have pamphlets, we have information for resources, we have condoms, and they all get that when they leave. Next. So what we've done here at the jail, here to give you some context, the average length of stay for our facility for 2023 was about 10 days. In 2022 it was about 11 days, and in 2021 it was about 12 days. And so you can see that we have a rapid turnover, and across all the years, between 55 to 60% of arrestees are incarcerated for 3 days or less. And over those same years, over 76% of arrestees are here or 7 days or less. So we do miss a lot of people that come and go very quickly, whether they have served sentence, whether they get transferred, or whether they get out on bond. And so the numbers in the red are the number of individuals that we actually treated in those years. And as you can see, from 2021 all the way to now, all the numbers are increasing. The number of people coming in with Suboxone, methadone are increasing. Next. So what we partnered with George Mason University in order to do Empowered Community Opioid Project, which is a program that where we have peers that are assisting individuals with SUD get linked to resources upon their release from jail. And the target of this are individuals incarcerated from less than 1 day to 5 days releasers, because we do have a lot of turnover early on. Next. One thing we initiated is a bridge device. This is manufactured by Massimo. The bridge device is a percutaneous nerve field stimulator, which helps alleviate opioid withdrawal symptoms. I mean, when individuals come in and we're waiting to, they're going to go through withdrawal, and we're waiting for either verification or time for them to see the provider, we can put this bridge device on, and miraculously within 30 minutes, somebody who may have a very high COWS score, let's say 19, which is a severe withdrawal, they can go from a score of 19 down to 5 within 15, 30 minutes. And so this is a device that was FDA approved in 2017. And we are piloting this here at the jail and have had really good success with many people getting relief right away. Those that don't get relief, we still use medications. We still get all the medications that help with the symptoms, from ibuprofen to things for nausea. But I can tell you, this bridge device does work very well. Doesn't work on everybody, but for the majority of people, it has been helpful. Next. All right, so here's a late show top 10 barriers to implementing evidence-based treatment for substance use disorder. Next. Well, one, barriers, lack of resources. So we started out with our own budget. Then we got some grants, and when things were looking successful, and the county and the board of supervisors were seeing how such a problem in the county, then we got funding from the board of supervisors. We have churches that are involved, and we have lots and lots of volunteers. Overcrowding or lack of space. Well, we made it work with what we had. We developed dorms. We created pods where we can have our heart program, and so we just thought out of the box and see what we could do. Stigma. We educated the staff and inmates on stigma, and to this day, we're still doing that. And obviously, not everybody is on board with what we do, and so, but it's something that is an ongoing education for reducing the stigma. Security concerns. Well, we developed the SOPs and developed practices to mitigate diversion, as I had mentioned earlier. Barrier, short length of stay. That's when we developed our program with George Mason University. Next. Lack of continuity of care. Well, we took great pains in developing relationships with community partners, treatment centers, and the state SOTA, the State Opioid Treatment Authority, Diane O. She's my hero. We have a very active reentry coordinator. Limited access to medications. Well, I got initially waivered, but now we don't need to do the waiver. I used the DEA 3-day rule for methadone to help somebody get through withdrawal if they're withdrawn from methadone, and we created relationships with treatment centers and our state opioid treatment authority. Insufficient training and support. Well, obviously we still have issues with this. However, we're developing roll call trainings and creating blocks of training for deputies for yearly in-service training and new recruit training, and also training for our medical staff. Fragmented systems. We're very lucky. We already had really good ongoing relationships with multiple county agencies, from judicial, drug court, community corrections, CSB, Commonwealth Attorney, Fire, EMS, and we brought several departments together in a shared grant. And the last is legal and policy barriers. Well, we have to advocate for changing the law to make things less punitive and to make things a little bit easier for us to treat all of our patients. Next. And here's a graphic that I really like. It shows all the interconnections between the Chesterfield County Agency partnerships. I mean, everybody talks to everybody. And so I will have CSBs call me to tell me that there's a patient that's going to be coming into the jail. They have to do a sanction for 5 to 10 days. Can we continue their medication? Of course we can. And so that collaboration is really key in continuity of care, coming into the jail, getting treated in jail, and then when they get back out and go back to the CSB, and with a warm or even a hot handoff. And so we have a continuity all the way from the beginning to the end. Next. So here for some help and guidance for those facilities that don't have anything yet, or they're looking to develop something. Next, here are some resources. There's a jail-based medication assisted treatment by the NSA and the National Commission on Correctional Healthcare. NCCAC also put out a white paper about jails and MAT saving lives. Next. Here's a from SAMHSA. Here's a use of medication-assisted treatment for opioid use disorder in criminal justice settings. Very good resource. Next. Medication-assisted treatment for opioid use disorder in jails and prisons by the National Council for Behavioral Health. Has lots of checklists and different things and different components to help you develop your program. Next. So here's more. They have a lot of tables. They have a lot of other resources for training. Next. Here's a document for primary care clinics, which I like this one because it has, there's a section in there that has the role of different individuals, job descriptions, in case you're trying to figure out, okay, who do we hire to help us? And so here they have all the job descriptions and so that you don't have to think about it. Next. And here's another handbook for primary care. It's very extensive, has even, it has sample progress notes on how to do your notes for the patients that you're treating. And so this is a very good, also a very good resource. Next. And this is my future vision for treatment. I saw this ad and I got this from Laura Yeager. So sorry, Laura, still in your slide. My doctor helps me manage my diabetes, my high cholesterol, and my opioid use disorder, because this is a chronic disease and it should be treated just like any other chronic disease and not have any stigma attached to it. Next. And here, all the resources I just said in this presentation, if you scan this QR code, it goes to my Dropbox, and all the resources are there that you can download. Thank you.
Thanks so much, Dr. Gay. What a wonderful presentation, so full of information. And we will be including these resources on the resource sheet that will be sent out to everyone following the presentation, as well as the slides and the link to the recording. There are a few questions that have come up that you might be able to help us with, Dr. Gay.
Okay.
Kathleen asks, what can be done with the OTP programs and the inconsistency in methadone dosing protocols? Too many people are allowed to continue at doses that are not therapeutic and continue to use illicit substances with full knowledge of the OTP program.
Well, part of that, just to let everybody know, I am an internal medicine physician. I'm not an addiction specialist, but I think over the last few years, I've read a lot that I've become a specialist. But, we talk to the treatment centers and find out, we look at what they've been doing and try to continue what they're doing. As far as people coming in and having other substances, we are treating opioid use disorder. We are not treating cocaine use disorder. We're not treating alcohol use disorder. We're not treating meth use disorder. And so I try to look for, when we do our urine drug screens, I do find a lot of individuals have these other things in their urine, but they don't have opiates and they may not have fentanyl. So if I think we're doing a good job, and I think the medicine is doing a good job, that there aren't these other illicit substances, other opiates. It's just buprenorphine. But so just like Mr. Gordon said, we have to treat. We still have to treat, because we're not treating those other disorders with medication at the moment, because there aren't any. And so to help with that is where Carrie, my colleague, comes in and helps with the criminally addictive thinking, the SUD programming that we have, all the evidence-based program that we do, to even try to help bridge that gap. Hope that answers the question.
Thank you. And Teresa asks, once a person is released, what happens with the methadone that was not dispensed?
The methadone that's not dispensed is discarded with my 2 RNs. And so they discard it. We record it on a sheet, and we also send it back. We send a copy to the treatment center to let them know that there were 3 remaining because the patient got out. They were destroyed, and we have a copy that we keep on site.
Thank you. And there's a question, where are you getting your methadone to utilize the 72-hour rule? And also, how can facilities get access to your facility standard operating procedures?
Well, my email is on the slide. You can email me directly, and I don't remember. I think I put it in my resources on this the QR code. But if not, just email me, and I'll send you a copy. And the other part of that question was what's the other part? The first part of it.
How are you getting your methadone to use the 72-hour rule?
So what we do is I have a contract with a local pharmacy, Westwood Pharmacy here in Richmond, and I can call them, and I get the dose that the patient is on in order to while I'm waiting for more verification. I get an initial verification of the dose, so I can get to 3 days while we set up for approval for take-home doses to come to the jail.
Thank you. Here's another question. Is everyone on medication-assisted treatment in the HARP program? Is it mandatory that they go into HARP if they are on MAT?
No, no, it's not mandatory. HARP is a voluntary program. And so, no, we have several individuals that are not on there, but they're in different pods of the jail. We have some that are on work release. And so we just keep up with those individuals also, and they get individual counseling with our clinicians to help with their programming.
Thank you. And Elizabeth has her hand up. Elizabeth, I've invited you to unmute. I'll have to respond to the ask to unmute, Elizabeth. While waiting for Elizabeth, another question came up about how are you sending your e-prescriptions? Our program won't allow this yet.
I have a digital key that only works on my laptop, and so I insert my digital key and access the electronic prescribing program with my pharmacy, and with that it allows me to order electronic ordering of opiates.
They are not in HARP and is in work release or other pods. Do they still get the reentry services?
Yes, everybody, reentry is for every individual that comes through the jail, not just HARP.
Okay, thank you.
You're welcome.
What a wonderful presentation, and just full of wonderful information. Can't say wonderful enough, I think. But I do want to give Carrie some time to do her presentation. And I know that you two are a closely knit team. So thank you again, Dr. Gay. And now we'll bring Carrie Rhodes on to talk more about the HARP program and the reentry program.
Slides up here. All right, are you guys seeing that okay?
Yes.
Okay,
Yes.
perfect. All right, so I'm Carrie Rhodes, and I am the Director of Behavioral and Mental Health here in the Chesterfield County Jail. And we have had a behavioral health division officially since July, so it is a new creation, and I think it's a real testament to our leadership here in the Chesterfield County Jail that we really have prioritized the needs of the population that we care for. I've been a therapist for 30 years here in the state of Virginia and worked in nearly every setting known to man, and never saw myself working in a correctional facility. I've been here in the Chesterfield County Jail in one capacity or another for the last 3 years. And I think the thing that qualifies me probably most is the fact that for me, this is a personal fight. You see a picture on this slide of my son and my daughter. My son died of an overdose in 2019, and he fell in with the shoulder surgery and the opioids that we managed his pain with. And, you know, I learned in the fire, which is really not a good place for people to learn, and not what I would recommend, because we didn't win. And, you know, when we lost Taylor, I swore that I would, you know, take some time to figure out, you know, there were a lot of gaps along the way for us in our journey, and people were dying in those gaps, and Taylor died in that gap. And here in the Chesterfield County Jail, you know, I have the ability to plug some of those gaps and create mental health resources and programming in this jail that I don't even, we say it's out of the box, but I don't think we have a box. I mean, the sheriff has really allowed us to bring in any modality that is helpful to people. There's not one path in this arena. I mean, MAT is a really important piece of recovery. I believe had Taylor had access to MAT, he'd still be here. He had a 96% chance of relapsing without it. And it is why he's not here today. So I think what you know, Steve Gorman and what Dr. Gay are talking about, it's very important for people to have options and to have access to MAT. You know, for me, 3 years ago, I walked into the Chesterfield County Jail, and that is actually me on day one in the male pod. And the sheriff brought me through to show me what he was doing. And I ended up sharing my story with the men and women's pods and HARP, and was just so profoundly blown away by what they were doing in a jail. I wanted to be part of it, and I started volunteering my time. And then today I sit in a seat as the Director of Behavioral and Mental Health for the sheriff, and am incredibly proud of the HARP program and the, you know, programming we provide throughout the jail. So why a program like HARP? So, you know, HARP is a multifaceted kind of holistic TC program here in the jail with, you know, a focus on prevention, treatment, and recovery. And it stands today, the name change it's gone through many phases of name changes, but today it stands for Helping Addicts Recover Progressively. You see a picture of some of my male inmates, and they all have their hands under their eyes. They're doing something called tapping, which is one of the out of the box treatments that we provide here in the jail. But we know that we need better tools. You know, I don't have the same lens I had going in. I was a very traditionally trained therapist, very cognitive behavioral in nature. But that's just not how trauma works. And a majority of the individuals, and you heard a lot of statistics from Dr. Gay and Steve Gorman, and I don't think in numbers. I think in terms of people, because every time I see that, like I saw that AI created stadium, and I think, you know, that's 112,000 families like me, right, who don't have their loved one, and the folks in our jail are people's children, spouses, brothers, sisters, and it matters. And so, you know, I think one of the secrets in HARP is that in a correctional setting, we care for people. We don't see them as numbers, they're people, and they safety and connection, which I believe is the foundation for all healing and treatment. Without that, you're not going to get very far. You know, one of the pieces that we talked about, and I'm going to talk about this a little bit further on, but within 3 months of release from custody, 75% of formerly incarcerated individuals with an opioid use disorder will relapse, and 40 to 50% of those are rearrested for a new crime within that first year. And so we know that within, you know, the first 60 to 90 days that they get out, whatever we do with them is very important. And we have an amazing reentry coordinator here in our jail. She is, she's a one-man show. How she does what she does, I do not know, but we have a team of, we partner really well in the community with recovery organizations. And when you leave HARP, we don't stop at the door. We are here as long as you need us. The sheriff has an open door policy, and what it means is that it doesn't matter who you are. If you are struggling and you need help, you can ring the doorbell of our jail 24 hours a day. We will let you in without charges. We will give you a bed, and our team will come down the next morning and figure out what you need. If you want to, people from the outside come into HARP and from the recovery community, all of our alumni or past participants are allowed to come back in and participate in programming on a daily basis, and they do. And so, you know, to me, the why for HARP is that 95% of all incarcerated folks, whether it's state or federally, are going to eventually return home. And that means they're going to be your neighbor. And if you think not in my neighborhood or not me, you're wrong, because all of us know people that struggle, you know, with this disease. And it is not a choice. It is not a moral failing. We've talked about that. You know, we've moved the bar for reward in the brain, and it's very difficult to move it back. The cycle, when Taylor, my son, was struggling in his addiction and our family was circling the drain on a daily basis, I had a therapist friend of mine say, "Gosh, Carrie, we just need to pray for jail." And I thought, are you crazy? There's no scenario in which I'm going to pray that my child ends up in jail. But had I known about what we were doing in Chesterfield, I would have maybe prayed for jail, because I believe what we're doing here is we're changing the trajectory of people's lives. People who participate in HARP are 75% less likely to recidivate. And our overdose rate is about 3%, which is far better than the national average, which is about 12%. And so, you know, we know that we're saving lives, and that, you know, if you leave our program and you relapse, there's never an "I told you so." There's never a, you know, you can't access services. It's, "We're glad you're alive, and come on, let's figure out what we need to do this time." This is just a little rundown. This is the female pod in HARP. And you can kind of see the connection that happens daily. But HARP is unique in that it is a peer-to-peer run program. And what I mean by that is that every peer in this program volunteers or applies to be there. A judge cannot put you in our program. The sheriff cannot put you in the program, and nor can any of my staff. Every person that enters the program wants to be there, and they are actually interviewed by the leaders, or what we call the mentors in our program. And so the mentors decide who gets in, who gets out. And if people are not working the program, if they're not, you know, if they're just in there because they think this is a little easier place to do their time, you know, they don't last very long. We also provide mental health services and trauma treatment for our participants. And that has been, you know, a real change, and something that the sheriff has prioritized, and that my team really tries. And the sheriff is actually walking in, so I'm hoping he's going to come sit beside me over here. But we've really prioritized here in the jail. And so we do a lot of really out of the box things. It's not, you cannot think your way out of trauma. And, you know, I didn't really understand that until my own trauma was so great that I thought, how am I ever going to function, much less be a therapist? And so we use a lot of somatic treatment, and we throw everything in the kitchen sink at it. We want our folks to leave with so many tools to regulate their nervous systems, that they don't even know which ones that, you know, they're gonna go to. And we use a lot of evidence-based groups, which I'm going to go through a little bit more as we go along. Like I said, we have a really amazing reentry program, because it's not there. This is a lifelong issue for people. It's not like, oh, you're fixed. So we know that, that warm handoff, every person leaves with a suitcase, clothing. We have grants for, some of our recovery organizations, and we'll grant 30 to 60 days of someone's stay while they get on their feet and, figure out, life on the outside, because recovery inside jail is very different than recovery outside. We have a community outreach piece that I'll talk about in a second, but we actually go into schools and we teach what our clinical team teaches our inmates to school children. We have a spiritual component. We have, we represent all faiths in here, but inmates are, they see pastors and clergy on a weekly basis. We do provide that MAT, and we feel like that's incredibly important, because this is a brain disease, and we need to recognize that when we've moved reward, that we've got to do things to help people put their feet back on the ground. We also have family night in the jail. There are not many jails that do family night, but we feel like it's really important. We take a lot of risk. The guy sitting beside me is he's kind of changed the way we do things in here. But they're repairing the family systems and helping people re-enter that is really important. And then we do a lot of education and training, not only with our staff, with the community, with our inmates. And like I said, aftercare is a big piece of it. So while I have the sheriff here, we don't normally have him in here, but I'm gonna let him kind of maybe speak to some of this with me.
Oh, okay. I stepped into the middle of this. Hello. I don't know if I'm speaking to one or a group.
You're speaking to 100 people.
Oh, speaking to 100 people.
All over the state.
Good morning. My name is Carl Leonard. I'm the sheriff in Chesterfield County, and HARP was something that I saw necessary back in 2016. It is an amazing program, and I'm often put on the spot to tell about it. You can't describe HARP. You have to come here, visit, and actually see it. It's a living organism unto itself. It changes every day. It looks nothing today like it did a year ago, yet alone 7 years ago when we started it. It is truly a successful program based on the fact that the peers, we can't stress the peers enough. And drugs is not a part of our addiction recovery program. Drugs have nothing to do with the addiction. That's the solution to the problem. It is not the problem. So we really invest a lot. When I say invest a lot, it's a lot of man hours, it's a lot of money, it's a lot of effort in really peeling those onion layers back to identify that trauma. Because until we fix the trauma, or at least give you the tools to now cope with whatever makes you feel the need to use drugs to mask that pain or void, we're not going to be successful. So we are a trauma-based, peer-led recovery program that is really hard to describe. It's extremely unconventional, but this is an unconventional epidemic we're in, and you can't throw traditional solutions at it. So we're breaking the mold, we're breaking the rules, quite honestly, but we're having some great success, which has been validated by a number of external studies. So I could speak forever about it. I'll let Carrie get back to doing her business.
Well, but like you said, so that peer-to-peer piece, and that's where we kind of are on our slides, super important. And so you see in some of these pictures, they're giving back to each other. We have a HARP family inside and outside of the jail, and they lead groups on the pods every day, leading meditation. You see up in the corner here, one of my inmates tapping with another one. And that's been one of the, really amazing things is as we give them tools, I want to give people tools that they don't need us for, right? Tools where they can regulate their nervous systems and they can calm themselves down without using drugs and numbing. And so, we really have a lot of things available to people in AA. Any route to recovery is good to us. Like whatever your path is, we want to support that. And so that's, I think that peer-to-peer piece and it's voluntary, right? So nobody's put there. And that, I think that makes a big difference in so much of what we're doing. In terms of our mental health, we teach classes, we have psychoeducational classes. We're doing a lot of resourcing whole group. HARP consists of at any given time between, 80 to 110 inmates. So about a third of our jail are HARP participants. They could be there anywhere from 30 days to 18 months, some 2 years, just depending on, how long they're sentenced and how actively they're participating in the program. We have a phased approach to HARP. So it starts out, they do their individual step work and peer-to-peer, and then they do, a lot of psychoeducational resourcing and then individual trauma therapy. And like the sheriff said, it's really important to realize that, we cannot treat addiction trying to extinguish behaviors. That is like whack-a-mole. You've got to go to what drives the behaviors and create, a situation where we're not just band-aiding a problem, we're actually going to the bullet holes and we're treating that. And that is, what we do. And we really, like, for me, like, trauma is not in the brain. Trauma is in the body. Trauma is stored in the body. Anybody on this call who's ever read The Body Keeps the Score. So we talk about, for mental health, it's this body-mind connection. Well, so many of our folks that are incarcerated haven't been in their bodies in years. And so it's a very new concept to teach them ways to self-regulate the nervous system. And like I said, and create safety in the body. Because I talk about this all the time, if you're in essence running from the bear and you're in survival, your body prioritizes that survival. It does not prioritize healing. It does not prioritize physical illness. It prioritizes survival. And so we really work hard to take our folks out of survival and then really go to the core issues that are driving the addiction. And addiction is a broadly defined term in here. It's not just drugs. I mean, addiction can be to shopping, working, overachievement, perfection. One of my inmates, he says, we're all recovering from something. So true, right? And so we use kind of top-down treatment, mindfulness, cognitive behavioral therapy, DBT, and then bottom-up kinds of treatment, which are more somatically or body-based. So EMDR, EFT, which is the tapping, havening, which creates safety in the body. And then vagus nerve exercises. And we use a program out of the University of Utah called MORE. It's called Mindfulness Oriented Recovery Enhancement, but it's meditation specifically kind of geared for addiction and actually chronic pain management with opioids. We have trauma-informed yoga, do a lot of creativity, therapeutic writing, music. We use anything we can to help people kind of feel safe in their bodies and access, the things that they need to heal. This might be a little out of the norm in here, but some of you, if you follow the Chesterfield County Jail, we have a TikTok and it's called Harp Talk. And we actually share a lot of the tools that we use in here. In the summer, we actually targeted Jelly Roll, and he made a surprise appearance in our jail and spent 3.5 hours singing, talking to our men and women. And this is just a little piece of what he had to say. And we were shocked. He was following our TikTok and the tools we were using and the tapping, but I'm going to play you guys just a little clip of this. I hope you guys can hear it, but we'll see how it works.
Well, first of all, let me just say, I heard y'all need an effect. Before y'all started calling. This crazy shit called happening. One, two, three, four.
So needless to say, it was a pretty profound experience for everybody on that day, but it gives you kind of a little glimpse into what HARP's about and like the energy that exists in there. And, you know, like the sheriff said, it's so hard to put into words what it's about, but I'll tell you this, on any given day, if I'm struggling or having a day, like I just go sit on the pod. It's one of the most healing places I've ever been, and that is a testament to the people that laid the foundation for what it is today. And we're always trying to make it better. I'm gonna skip this because Dr. Gay covered this. When we talk about reentry and recovery, our reentry coordinator, like I said, amazing what she does on the daily basis, but she, you know, like we have an exit plan with every inmate in HARP, anybody requesting any type of services in the jail, you know, she provides those services to them. We have recovery housing and programming and resources that we connect our folks to on the outside. Like I said, off the street participation, people coming off the street all the time. Most jails, that's a huge security risk, and it is for us. And our deputies do have to go above and beyond, you know, to support that. And, you know, I'm incredibly grateful for all the hard work they do to keep everybody safe. You know, Dr. Gay mentioned the ECOP team with James Madison. You know, they grab our short timers, our people who are in and out of the jail, and typically like less than 3 days, but they coordinate same day MAT service, housing, transportation, whatever our folks, you know, need. Like I said, HARP is a longer stay in the jail. We also have a nonprofit that was created to support our HARP folks when they get out. So we've done things from like helping pay driver's license fees to help someone get a job, to scholarshiping them more time in a recovery house, or just helping with whatever they need, whatever supports they may need out in the community. And we've done a lot of work. We have a reentry council that our reentry person started, and so it's a great, I think there's over 200 members where everybody, like all over the Central Virginia, they come together and share resources. Because that's the deal, y'all. You know, it's going to take, nobody has the answer in this. It's going to take all of us coming together as a community and doing our part wherever we are sitting, right? That's incredibly important. And like I said, the sheriff, I don't know any jail in the country where you can just ring the doorbell and come back in. But every day that is what happens, and people come in and sometimes they're struggling and they're high and, you know, and they just need help. And so we dispense our team to them. We take people out of the pod to help them. And that, you know, that's part of what we do. From a prevention standpoint, you know, I think, you know, we need to start really looking at, and as a state, putting some resources to keep people out of the river. And we were asked last year to go into a high school and tell kids why they didn't want to come to jail. And I said, well, we're absolutely not going to do that. But we will go in and teach kids what I think high school and middle school kids need to know about what they're facing. And we need to go upstream and figure out why people are falling in. We talk about a mental health crisis all the time, right? Our kids are in a mental health crisis, but we're not doing anything to teach kids how to regulate their nervous systems. And, you know, and they're hooked up to technology, which is so dysregulating all day long. And we're not really educating our students with the fidelity or the urgency that I think we need to. So when we were asked last year to go out, we created a program, and it's called I Never Thought It'd Be Me. This is these are some of the folks on our team, and we take out 4 inmates and we go into schools. I tell my story, but they tell their stories. And as they tell their story, they teach students about mental health and managing stress and the difference in, you know, a false tap and actually something that gives your nervous system relief. They teach about fentanyl, xylazine, Narcan, and that it's not just pot and alcohol, right? And so when you have people with lived experience, you know, who are amazing people teaching, you really get kids' attention. And I'm gonna tell you, it's hard to get kids' attention these days. So this is a program we offer free of charge. We go out into high schools and middle schools close to us and provide this. This is a little piece of, this is the program I Never Thought It'd Be Me. And I'm gonna share a little bit of it with you guys. Gives you kind of an idea of kind of what we're talking about.
I've been using since I was 14. I started out by just smoking weed with my friends. You know, when I was in middle school, I had this deep-rooted feeling that I knew it was wrong, and I knew it was something that could take me other places, but I just, you know, everyone would tell me, you know, it's just smoking weed, you know, it's fun, it's something that, you know, we all do together, and, you know, I eventually started enjoying it. I only smoked weed on the weekends, and it went from me smoking on the weekends to me bringing it home to my mom's house, and I had everything I needed to smoke at my house during the weekdays. I smoked before school, after school, whenever I could.
I was really big into sports. Baseball was my thing. That's all I ever did was baseball and play guitar. And around the age of 16 and 17 is where I thought I could do something with baseball, go somewhere with it. And then something happened. I tore my ACL. After the surgery, they prescribed me pain medication, oxycodone, and I gained a liking to it, being that I was already experiencing other drugs that were just fun party drugs, which I thought they were. Ultimately, it became, you know, dependence.
I got started using when I was around 9, 10 years old. I had low self-esteem issues. I wanted to be where everybody else wanted to be, which is the lifestyle. So I just pretty much did anything that I thought would get me closer to that lifestyle. I started smoking weed, drinking. First drug I did was marijuana. And then all the way up until I was 18. When I was 18, I did cocaine for the first time.
And it all transpired basically from, I look back at the bus stop, starting at the bus stop.
My mother left me when I was 2 years old on Christmas morning, so I didn't have family. Well, I did have my dad, but he was abusive. He was physically abusive, mentally abusive. He was an alcoholic. He was also on drugs, crack, heroin, probably everything on the book.
You know, like I just grew up around people that was selling drugs. Like I used to watch my father sell drugs and do drugs. And I always said that'll never be me. I'll never do the things my father did. But it came to a point where I was just hanging out with older people and the lifestyle kind of reeled me in. So I started selling drugs.
She was on Percocets, and something clicked in my brain, and I was like, man, I'm gonna try one of those.
I always grew up saying I wouldn't be like my dad. And here I am. I kind of went right into his footsteps. I started drinking at a young age with not feeling enough. And I would take those behaviors and those habits to school with me. And I would lure the crowd in. And there were my friends.
Marijuana came to a point where it wasn't enough for me. It didn't get me as high as I wanted it to, so I went to crack. Well, I went to cocaine, excuse me. I started sniffing cocaine at 16 years old, and at 17 years old, I was smoking crack. I never thought it'd be me. I never thought it'd be me.
Never thought it would be me.
I never thought this would be me.
I never thought this would be me.
I never thought this would be me.
I never thought it'd be me. I never thought it would be me. I never thought it would be me.
I never thought this would be me.
I never thought this would be me.
I never thought this would have been me.
I never thought this would be me.
I never thought it would be me. I never thought it would be me. I never thought it would be me. I never thought it would be me.
So, that's just a little piece of what we do. And like I said, we teach a lot of the same things in that presentation that we teach here in HARP, from the neuroscience behind addiction to how we use actually Doritos, and we call them doparitos to show how, when you move the bar for normal, when you move outside of the brain with a substance, like, and you rewire that reward system, what happens. And so, we try to, not make it complicated, because I don't, we want people to really understand what's going on. I think for us too in HARP, a thing that makes us really unique is that recovery is really not about abstinence here. Recovery is, we look at it more holistically. It's really recovering your true self, and a reconnection to your emotions and your body, which a lot of people, in survival, we have to give up. And so, that those that armor or and those survival skills that we use to survive, were necessary, but now they're not. And so, I tell people whatever those life jacket things that helped you survive, now just weigh you down. And so, it's really a process of helping people put those things down and step into themselves. And for a lot of them, it's really for the first time. And I can't tell you how rewarding it is to watch it happen. And you can see the beautiful people in that video. And a lot of them are out in recovery today. So, we talk about addiction is a problem, but it's not the problem. It's just their solution to a problem. But we try to look at it in a bigger realm because, I have people who, we've gotten out of jail and they weren't on a drug, but then now they can't pay their rent because they're gambling. So if you don't deal with the core issues that drive addiction, you're not even dealing with half the problem. And I think that's why the mental health piece is just so, so very important in all of this. I gave you a mental health page that I use when I do training. I've done, we have taught, I guess I've taught probably over 200 first responders trauma tapping. You see that used in the jail. It's what we teach our peers. I actually just trained another 80 inmates yesterday in the jail in trauma tapping. But having, tools that you can use if you're curious about that. I have a lot of resources on this page about some of the tools that we use. And my email, I don't know why it's not on my page, but I will put it in the chat for everybody. But thank you guys for having us today. It's really an honor to be asked to share what we do. And it's really an honor to be part of what the Chesterfield County Sheriff's Department has created here.
Oh my gosh, Carrie, amazing. Somebody put in the Q&A, awesome. So
Thank you.
Presentation, incredible what you all are accomplishing there, and we're so grateful to have a glimpse into it. Just a note that we will include Carrie's link shown on the QR code on our resource page, and we will also be sending that out to everyone. We do have a few questions in the Q&A that I'll give you, and I'll keep track if anybody raises their hand and try to unmute you. Are the inmates who are on medication-assisted treatment housed in the general population, or are they separated from others in a special housing or program unit?
They are not separated. If you're on MAT in the jail, you're housed either in general population and in HARP. We, like Dr. Gay said, we used to have a special pod called SMART for anybody who was on MAT, but we integrated that into HARP because I felt like, why are we keeping this separate? This is part of, this is part of treatment. And and the real issue was diversion. That's not everybody's path. MAT is not going to be everybody's path, and it's not the majority of the people's path in HARP, but it's a path that's available to them. And like I said, we don't really dictate your path. We just want to make sure you're educated about your options, and we have the ability to make those available to you.
Thank you. So are the folks who select or volunteer to be part of the HARP program, are they in a separate pod?
Yes, they are. So HARP, yep. So HARP is housed actually upstairs in our jail. We have 2 female pods that are connected, and then we have 3 male pods that are connected. But HARP is it's separated. They are separated, and the programming and the peer-to-peer. They program from about 8:30 in the morning till 4:30 every single day. Nobody's sitting around. It is all recovery work, peer-to-peer classes, therapy. They are really, really busy in the evening. We have programming as well. We have NA, we have educational classes like logistics and horticulture, training them for job skills. And so there's a lot going on. So if their mentality coming into HARP is I'm just going to sit here and do nothing, that is not at all what it's a real rude awakening. It is intense recovery work, but it's great because we have it's great because I have a captive audience. Nobody's no showing. Right. And that's a real benefit as somebody who came out of private practice and communities, everybody here you're in for the day. So, it's great that we have that kind of cohesiveness, because I think that's what's going to take. We need long-term care for this epidemic.
Incredible. So can inmates who refuse to meet with a therapist or participate in the program still receive the medication?
Sure. Yeah. Yeah, so they like, they do not have to participate in counseling. That is, that's optional. And they don't have to participate in HARP. If anybody like, we have people who they decide HARP's not for them and they leave, and that's okay. And then we have people that are removed from HARP because of behaviors, because of things that are not conducive or take away from the recovery of others. And my mindset is, we give a million chances in here, because I don't know, like maybe the 26th time you come through, maybe that's the time for you. I don't know, but I think everybody deserves, a chance to heal, and so that's what we give people here. So, but everybody can have their own path.
Great. Yeah, I know we're moving from saying medication assisted treatment to medications for opioid use disorder.
Yep.
Medications can also be used for other addictions, but for some people, that's the primary treatment. So, thank you. I see that April Hutchinson,
she's one of my rock stars on my team. Yeah.
She chimed in and left her email in the Q&A if anybody's interested in learning more about the reentry coordinator, reentry program. And just we have some other comments. I see awesome, phenomenal, and those comments like that. But how can a person participate as a volunteer if they have several years of recovery?
So we have people come in all the time, and we vet our people really, really well. We try not to duplicate services. But, just contacting our programs director, her name's Bailey Hilliard. And, like I said, we have people come in, tell their stories all the time, and share their path to recovery, because maybe that's so they can contact me or Miss Hilliard.
Okay. And I noticed you had like AA meetings and NA meetings. Are those outside groups?
They are. Mm-hmm. They are. Yep. They're outside groups that come in. We have a men's alliance group that comes in. So we have multiple groups that come in and provide, those outside resources. And they also, are providing links to the community, so that when people, do leave, that they have connections within the community that are supportive of their recovery. I can't say enough how important that is. That people really need to be surrounded by other people in recovery, especially early on in their journey in this.
Well, thank you. I see April also put Bailey's email in the Q&A as well, in case anybody's interested in contacting the programs department to become a volunteer. So that's terrific. The only other question is one that I had about using telehealth. Do you all use telehealth to connect people either for their medical care or their recovery services?
We do not use that for recovery services. I mean, we do, Dr. Gay could speak to that in terms of the medical piece. He unmuted, but.
Yeah, we have used telehealth services for individuals that, if their treatment center wants to see them and follow up with them while they're here, we have set up several appointments for that. So we're looking to do more of that, so that because it gets very difficult when you have to try to take people out of the jail and transport them to different places, because it takes 2 deputies and it takes time. And so telehealth is a good way to do that. And I think that, the rules and the regulations have lightened up on the use of that.
Okay.
Yeah. And then we also partner with a therapist in Sweden through the Peaceful Heart Network, and he does some programming with our male and female heart pods. And like, so that's Sweden, but so that we partner where it makes sense.
Yeah, that's you definitely need some telecommunications.
Yeah. Although I'm always saying I'm available to go to Sweden.
Right.
Me too.
Oh, sorry, go ahead.
No,
He said me too. He wants to come with me when we go to Sweden.
I'm going to Sweden too.
Well, if you're not in the office, we'll know where you've gone.
That's right.
Danielle, I unmuted you. So did you have a question?
Can you hear me now?
Yes.
Hi, so I'm actually under my HSA's name, but my name is Nicole Folks.
Okay.
And I'm currently the DON at Richmond City Justice Center. And I just wanted to I wanted to talk to you guys earlier, but I was having technical difficulties. But when you guys said telehealth, I did want to speak to that because here at Richmond City, we are revamping our MAT MOUD program. And currently, that is what we are doing. We are trying to provide a full service MAT program to where they're able to speak with the provider, they're able to speak with the counselors, they're able to do everything they would be able to do if they were released here at Richmond City. And we have actually done my first patient, and it went very well. So it can be done.
Thank you for sharing that. Appreciate that. Well, we're running out of time. I just have a few more minutes. Just want to check and see if there are any other questions. I'm checking on the list. Also, a couple of reminders. As I mentioned, we will be sending out a resource list to everyone, as well as making the slides and the recording of these presentations available. So watch your emails. It will come through the Eventbrite registration list. We haven't quite figured out the logistics if we'll download the list and send it directly to you from Bay Rivers Telehealth Alliance. So watch your emails for more information. Also, if you've registered for this session, you have not registered for our next session, please go back to Eventbrite and register. Next month, on March 27th, we'll be hearing from the dynamic trio from Fairfax County about their program. Sheriff Kincaid and Laura Yeager and Sahana Kapoor will be sharing about the programs there that they've implemented, and you don't want to miss that day. I know that there is a conflict for some of you who are going to the Virginia Sheriff's Association meeting. Like I said, we will be recording, so you won't have to miss that presentation. Of course, we'll share the slides. So be sure, if you've only registered for one time, you have to register for each meeting. On the third meeting on April 24th, we'll be talking more about funding, because I know that's on everybody's mind. How are we going to, sounds wonderful. How are we going to pay for it? Especially you smaller counties who don't have the big budgets. So we'll have Tony McDowell from the Virginia Opioid Abatement Authority, and we're very excited that we will have another speaker coming that's not yet on your bios to talk about national and state resources for funding and strategies to go about finding funding, which our speakers today have also talked about in their county. And then I'll be talking a little bit more about working collaboratively with your partners and how that whole process works of building grants and grant writing. So be sure to sign up for all three webinars. And let's see, just checking my notes of what else I wanted to tell you. We'll have a brief survey that will be put in the chat that we really like to take just a couple minutes at the end of today to fill out, give us feedback on your experience of this webinar. And I would like to just wrap up by repeating some of the adjectives we've heard about today's presentations. Terrific, wonderful, amazing, phenomenal. Thank you all so much for participating today. And I'll just check one more time to see that we did have a couple more questions. Since we have a couple minutes and Dr. Gay is still here, these look like questions for you. Someone asked, I was under the impression that in order to use Suboxone or methadone in the jail setting, that substance use counseling is mandatory. Is that correct?
No, it's not mandatory. Studies have shown that it helps with starting the medication because that's what prevents overdose deaths. And so If you're waiting for somebody to have counseling first before you start the treatment, that person's may go out and start to use, and they won't have anything in their system to help block or prevent the overdose. So it's a harm reduction. That's the biggest thing as to why we do the medication is harm reduction. And no, you don't have to wait. It's nice to have it, and it's nice to work towards it, but you should not treat with medication in lieu of trying to get the program.
Gotcha. The same person asked, is all the Suboxone and methadone you prescribe name specific? I would imagine one would need non-name specific starter medication in the event someone comes to the jail on the weekend who didn't manage to bring their medication with them upon arrest.
Well, we have a majority of all of our medications are patient specific. We do have I have a stat box that I do have methadone in a stat box that's allowed by our Virginia rules, our legislation, that we can have starter medications. And so, such as buprenorphine, which is Schedule 3, we can have that in our stat box to use when the pharmacy is closed. But we still have to. It has to be under lock. Has to be behind 2 locks, and all the requisite recording of all the touches and the counting has to be there.
Carol, I've been trying to unmute you. I asked you to unmute. You'll need to respond on your end to actually unmute. You had your hand up. Oh, hand down. Okay. Well, thank you all for being here today. One last note that we will be sending you the survey. Don't see that in the chat, so we will send you a link. No, there is a link in the chat. Here's a link to the survey. So in that last couple minutes that you've set aside, if you would please click that link and give us some feedback. We would really appreciate it. Thank you so much for being on today's webinar. We look forward to seeing you again on March 27th for our next chapter in this amazing webinar series. Hope you all have a wonderful day. Thank you for being here.